Hello everyone, my name is Dr. Priti Anand and I'll be taking you through some important topics of maternal medicine. So maternal medicine, there are few topics which are very commonly asked in your exam, and one of them is venous thromboembolism. Now, first thing which comes to everybody's mind is that why are they so much care? Why do they care so much about venous thromboembolism? Why are they giving so many questions? So the reason is that it is one of the most common reason. It is one of the most highest risk factor of leading cause of direct maternal death in UK. Not even from today. If you go in the past, also since years, their embrace code this. So it is very important to know this topic in and out. Secondly, the question comes, whom do you screen for or whom do you do a risk assessment? So everybody, all the pregnant, non-pregnant females who are coming to the OPDs are assessed, okay, whenever they are getting any medical management or surgical management. Specifically, we'll talk about the pregnancies over here because it is an obstetric topic. So all the females who are coming for the preconceptional counseling in the antenatal care, first, second, third trimester, intrapartum, postpartum, everybody will be screened for the risk factors at every point. So that means you have to be very well known. You have to very well understand and remember these risk factors. They are very important because they will be categorized into high risk, intermediate risk, low or no risk. And on the basis of them, you will give them the advice about the venous thromboembolism, whether you require the treatment, whether you require treatment right from the first trimester, whether you require treatment later in the pregnancy from 28 weeks, or you do not require treatment, you just require a additional conservative management, like giving them advice about the mobilization, hydration, etc. So this table is very important. And the second table, which tells us where they stand, what is the score of their risk factors, because if the score is 4 or above, you will start their venous thromboembolism prophylaxis right from when they get pregnant. Okay. If it is 3, then they will be started from 28 weeks during the pregnancy. If it is 2 during the pregnancy, they require general management like mobilization, hydration, etc. Postpartum, there is a little difference because if the score postpartum, as I told you, you'll assess the patient every time. So some patients might not have risk factors for the antenatal thromboprophylaxis. But postpartum, when you assess them, they may require the thromboprophylaxis because they had something like cesarean section in labor and they were very high BMI, or they required readmission, or because of many other reasons like multiple comorbidities they suffer from. Where the score may be 2 or more than 2, these patients will require thromboprophylaxis postpartum. So as I told you, you have to learn this table of risk factors as well as this scoring table, that where that patient stands, so that you can tell her, you can advise her, you can offer her treatment right from pregnancy in the third trimester, or she requires only postpartum care for thromboprophylaxis. So once you have decided that you're going to give this patient a thromboprophylaxis, so there are some patients who will, many patients will require the routine dose of low molecular weight heparin. That is according to the body weight, they are given some thromboprophylaxis. So this is the table which shows the various doses of enoxaparin, dalteparin and tenazepam according to the body weight they are given. And this is the pre-pregnancy weight or very early pregnancy weight, not the current weight. But some patients will require an additional dose, a higher dose. So these patients, you will always test before starting the low molecular weight heparin. That means all the patients will not require testing. Only the patients who have previous history of thromboembolism and family history of thromboembolism, they will require thrombophilia testing. Similarly, who has a previous history of unprovoked venous thromboembolism will require the EPLA testing. And patients who herself didn't have history of venous thromboembolism, but there were high risk factors in the family where asymptomatic pregnant female has a family history of venous thromboembolism, first degree relatives who was less than 50 years, or had that was provoked during pregnancy, COCs, or the presence of minor risk factors. So these patients require testing because these patients will require a higher dose. Above this, they will require a 50 to 75% above the regular dose or a therapeutic dose of low molecular heparin. And this need to be started very early in pregnancy, because now when the patient herself is a carrier of risk factor, or she's carrying a risk of venous thromboembolism because she has suffered it, then it comes under a score 4. Okay, so score 4, you start from very early in the pregnancy, continued for 6 weeks postpartum. and follow-up anticoagulants will be given under the care of hematologist. One very important thing which everybody has to remember is that any patient who has started venous thromboprophylaxis in pregnancy anytime, whether started from the first trimester, whether it started from 28 weeks, they will continue that therapy for 6 weeks postpartum. Okay. Then you don't reassess again and again. Once they have started, that means these patients will require it 6 weeks postpartum. But if somebody has developed risk factors post-pregnancy, postpartum period, and you have started thromboprophylaxis for them, then it is usually where the score is 2 and above, the thromboprophylaxis is given for 10 days. But if it is a continuing risk factor, where there has been more than 3 days, she is there for admission, she is quite prolonged for immobilization, then you can think of giving them 6 weeks thromboprophylaxis postpartum. Otherwise, it is 10 days if the scoring has been done after pregnancy, after delivery. Then this is the prophylaxis part. Now, some patients might develop thromboembolism in pregnancy also. So once you diagnose that there is somebody who is coming with the pulmonary embolism for that, say DVT or pulmonary embolism, whatever, let's see if pulmonary embolism, if they're coming, if you suspect that it is there. First of all, you will do assessment, go for everything will be done side by side, X-ray, ECG, blood test, and because of their high suspicion, you'll start her on therapeutic dose of low molecular weight heparin. Making sure that you also by the side see whether there are signs and symptoms of DVT or not. If they are there, then bilateral, both the legs compression ultrasound will be done. If it is not, then you will go back and check the X-ray. If X-ray is normal, still there is a suspicion. Then you have to do a V/Q scan to confirm pulmonary embolism. If X-ray is not normal and you have suspicion, then you do a CTPA. So this is the dose of low molecular weight heparin given in a therapeutic dose. Again, this is according to the weight of the patient. Okay. And these doses are directly asked in your exam. They directly give you the question where they actually want you to give the therapeutic dose. So options will be not low molecular weight heparin. Options will be 60 milligram twice daily low molecular weight heparin. So you need to know the dose according to the body weight. That is very important. If some patient of pulmonary embolism has a massive attack where she is in shock, collapse, RV dysfunctioning, it is very important to start them with the intravenous loading dose of unfractioned heparin, 80 units per kg with 18 units per kg per hour as a maintenance dose. So if there is a massive embolism, we will definitely make sure that we give them intravenous unfractioned heparin. In massive pulmonary embolism is confirmed, life-threatening, it is there, ischemic compromise is there, then thrombolysis can be done. And if the patient is not suitable for thrombolysis, then cardiothoracic surgeon definitely has to take a stand for thoraciectomy or embolectomy. Moving on to another important topic of maternal medicine, that is hypertension. Now, it is very important to know that whenever the maternal medicine you talk in pregnancy, you have to see that patient right from the starting, whether she was having this risk factor pre-pregnancy, antenatal, intrapartum, postpartum, and what is the risk factor in the newborn. Okay, so any medical problem, you have to answer everything in this format. Why? Because if she is a known case of preeclampsia in previous pregnancy and she is coming to you for preconceptional counseling, you will take in mind that from whenever she gets pregnant, I'll start with the aspirin. Okay, so every time whenever you are seeing any maternal medicine topic, read it in this format. In the patient who is on who all will require aspirin, so this is the table where the high risk and the moderate risk factors. If there is one high risk factor, they will require aspirin. If there are two or more moderate risk factors, then also in pre-pregnancy counseling, you will check, and in antenatal care, early pregnancy, you will see to start with the aspirin. Now, hypertension is there, and the other thing is the preeclampsia. So for the hypertension patients, only hypertension, no proteinuria, no other RFT, LFT derange, only hypertension is present. So they are hypertensive and they are severely hypertensive. So if the patient is just a hypertension, that is BP is 140/90 to 159 to 109, you do not routinely admit these patients. Antihypertensives also are started if the BP is above 140/90 and it is a persistent high. Whenever there is a target you set, you have to make sure that a target with the medicine should be 135/85 or less. In patients who are severely hypertensive, 160, 110 BP or above requires admission, requires indoor inpatient management with the antihypertensives. Now, how to assess them? So for simple hypertension patients, you can say mild to moderate variety. Once or twice weekly, call them in OPDs, whereas admitted patients require frequent monitoring. Urine dipstick, you do it once or twice a week for simple hypertensive patient. Definitely once it is diagnosed, at the time of diagnosis, you will definitely do. Then once or twice a week whenever they are coming to you. Daily for severe hypertension, because you want to know whether this hypertension is converting into preeclampsia or not. Then blood tests, massive blood counts, the measure of full blood count, liver and renal functions are done at presentation and then weekly in both the groups. And PIGF based testing, basically it is to see whether the patient has landing up in preeclampsia or not, is only done when you have a suspicion of preeclampsia developing. Fetal assessment in hypertensive patients, still I'm on hypertension. At every visit, you will check the heart rate. Ultrasound assessment need to be done at diagnosis, and if normal, you repeat every 2 to 4 weeks if it is required. For severe hypertension, you do an ultrasound at diagnosis and you repeat it every 2 weeks. CTG is only done for mild to moderate hypertensive patients if there is a clinical suspicion. That means that the patient has reduced movement, there is pain, vaginal bleeding, or there is deterioration of mental condition. And for severe hypertension, you do at diagnosis a CTG and then only if clinically indicated. Pre-eclampsia patients will have proteinuria. Apart from that, they may have liver or renal dysfunctionings as well. Now, all the patients with mild to moderate variety will require admission if there are clinical concerns, or if they actually score these patients on full press and prep S. So if they fall in the high risk categories, adverse events are expected, then they admit these patients wherever there is a concern of maternal and fetal well-being. Severe hypertension, usually they admit everybody to make sure that patients are managed well. Antihypertensives for patients usually start in both of them, but if it is a persistent high of 140/90 and above for mild to moderate variety, definitely you will start. And for target BP for everybody, it should be 135/85 or less. Blood pressure management, at least every 48 hours, simple preeclampsia, I mean mild to moderate preeclampsia, are monitored. And for the patients who are admitted with severe preeclampsia, very frequent monitoring is done. You do a urine dipstick, you only repeat if it is clinically indicated. For example, if there is new onset of signs and symptoms. Blood test, you will do at the time when it is diagnosed, then twice a week for mild to moderate preeclampsia and thrice a week for severe preeclampsia. Fetal assessment, heart sound at every time whenever the patient is visiting to you, ultrasound at diagnosis and every 2 weeks for both of them, and CTG at diagnosis and then only if clinically indicated. Any patient who is hypertensive in pregnancy, or any patient where you are going to continue the medication postpartum, or any patient with new development of hypertension postnatally, do remember the drug of choice is enalapril. Okay, so patients who are new onset, or you plan to give some postnatal hypertension to patients, so you always start with enalapril. Only patients who are Afro-Caribbeans, nifedipine is a drug of choice. If one medication is not able to control, you can give them with antenatal atenolol, labetalol, or you can swipe also. Third important topic is diabetes in pregnancy. So diabetes in pregnancy, there are basically the patients who are already diabetic, type 1, type 2, or somebody who will start with developing a gestational diabetes if you diagnose. Now, to diagnose gestational diabetes mellitus, 2 or 75 gram of oral GTT is done. Specifically for the patients who have BMI of above 30, these are asked in your exam. Previous baby weighing 4.5 kg or above, first degree related with diabetes, history of diabetes in previous pregnancy, or ethnicity where diabetes is very common. These patients will be offered test in between 24 to 28 weeks, except who has a history of GDM, where the testing will be done at very early in the whenever the pregnancy is diagnosed. And if that test is normal, again a repeat test will be done between 24 to 28 weeks. Now, GDM diagnosis is made. You have to make sure her FBS should be 5.6 millimole per liter or above, or her 2-hour postprandial glucose should be 7.8 or above. For any patient with any variety of diabetes in pregnancy, whether GDM type 1, type 2, targets should be these. Do remember these target levels are asked in your exam. Again, as I told you, study in this format, any medical problem is there. So pre-pregnancy, you have to make sure that if the patient is a known case of diabetes, you have to make sure that her hemoglobin HbA1c should be less than 6.5%, because otherwise it will be having adverse effects on pregnancy. Specifically, if it is more than 10%, you will advise against the pregnancy. Her renal test, her retinopathy test should be done. Folic acid 5 milligrams need to be given, and her all medications need to be checked, because the safe oral hypoglycemic drugs which are safe is basically metformin, and usually they consider others to be not very safe, so they replace them with insulin or metformin, whatever is safe and whatever the patient agrees on. So once it is diagnosed that the patient has gestational diabetes, you have to now check whether you'll start the treatment or not. So this is the patients who are not on any management. You diagnose them. You have made a diagnosis that she has a GDM. Now, if the FBH level is less than 7 millimole on diagnosis, it is okay. You can start with the exercise diet, see for 1 to 2 weeks. If the patient is not responding, you can add on the drugs. If the FBG is more than or equal to 7, you have to give insulin plus minus metformin. So insulin has to be given. Metformin can or cannot be given depending if everything is okay with insulin, you do not add up. 6 to 6.9 FBG is there and the patient is hydramnios or macroscopic baby, then you start the treatment with insulin. Antenatal management, the most important thing to remember is the retinal and renal assessment. If it is not done in the last 3 months, it has to be done once the patient is found pregnant. And if there is anything deranged, nephrologist, for example, if serum creatinine is very high, then you have to involve the multidisciplinary team. Rest the treatments are usually all okay, but I do remember I told you in the list of EcoSprint that type 1, type 2 diabetes are a high risk. So you will start with the EcoSprint. You will offer again a retinal assessment in between 16 to 20 weeks. If there was any problem in retinal checkup in first visit, you will plan delivery in type 1 and type 2 diabetic patients either by induction or elective cesarean section in between 37 to 38 plus 6 weeks. This is asked in your exam. If the GDM is uncomplicated, then 40 plus 6 weeks you can deliver. Same by induction or elective cesarean section. Monitoring throughout the intrapartum period should be done 1 to 2 hourly and make sure that the blood glucose is in between 4 to 7 millimole. Baby monitoring every 4 weeks from 28 to 36 weeks. And routine Doppler, BPP, FHR tracings before 38 weeks is not recommended. Neonatal care, once the patient is there with you, you will check the baby at least 1 to 2 hours after birth and make sure the blood glucose is 2 millimole. If it is not, then you have to see that the feeding is not okay. So you need to see the baby has to be given something intravenous and also monitor the baby for abnormal signs. And if the baby is not able to take the oral feed, then you have to reassess to check what needs to be done. Postnatal, once the patient has taken a treatment and delivered the baby, for type 1 diabetes patient, whatever the treatment she was earlier on, you skip on that treatment. Same is for type 2 also. And GDM patients discontinue, you will do the therapy, discontinuation will be done, but these patients will be kept on follow-up. So pre-existing diabetes, you will refer for diabetic care management. For GDM patients, you will test for blood glucose before transfer to the community. So at 6 to 13 weeks, you will do a full blood count. Offer full blood count or HbA1c after 13 weeks if not done before. And if they are found to be abnormal, then you have to refer them for the management to the diabetic advice to the physician, you can say, or diabetic clinic. Okay. So this is all from my side. I hope this lecture helps you all in your preparation for exam. So good luck, have a nice day, and thank you so much for watching me. Thank you so much.